Thank you, Pat, for kind of leading us into the direction of the future. I've known Pat for over 20 years. We got to meet, and I like to think, we're like-minded individuals, and we believe in the biology. I was trained by Blake Cady, who was probably the king of the biology theory, so I appreciate that, and I know that's where we're going. That's where we need to go. I'd also like to say that we opened a randomized clinical trial at Tulane for liver metastasis using the 9mm pink gun versus a cryoablation. There was no difference. No, I'm just kidding. Just kidding. All right, it gives me great pleasure to introduce my colleague and friend, Dr. Genevieve Maronge. Dr. Maronge is a native to the Southeast Louisiana region. She went to LSU undergrad, attended LSU Medical School, did her internal medicine residency at Ochsner, and then did her hem-onc oncology fellowship through LSU. And she's been in private practice in the local regional communities since finishing her training. And I look to her as a great resource with our North Shore patients that we share. And so, welcome, Genevieve.
All right. Okay. Thank you for the introduction. My name is Genevieve Maronge. Can you hear me? I can't hear. All right. Better now? Okay, great. As Dr. Corsetti said, my name is Genevieve Maronge. I'm a community oncologist with Mary Bird Perkins on the North Shore. I have been in Louisiana and training and practicing from the beginning and enjoy practicing here. In community oncology, I see a lot of breast cancer patients. That's my personal interest, and that's a lot of my practice. So I take it very seriously to try to stay up to date, which is very overwhelming, and that's a good problem because the research is booming so much. And Dr. Borgen gave a great kind of introduction to that. You would not have thought years ago with what you're describing, this 18-year-old with a breast cancer diagnosis, that she's been alive now 10 years on 13 lines of chemotherapy. And until we, achieve a cure, which is what we really want, the fact that she could live this long, you can tell from those pictures, she's living, even though she's having to go through this experience. And this idea of 13 lines of treatment, that also is a good opener to what I'm going to talk about. So I'm going to talk about updates in systemic therapy of breast cancer, and there was a lot of big kind of exciting changes in the metastatic setting that would likely be applicable to this patient. And speaking to this idea also of thinking there's just a few subtypes of breast cancer, there really, it's booming. I feel like we're on the tip of the iceberg of what we're going to find out with how much we can improve on precision medicine, really understanding more about breast cancer. And so the current updates kind of reflect that very well. I don't know if I can do this all in 35 minutes, but I tried to put what I thought was the most important first, so I can spend longer time there and rush through or finish if I need to. All right, let me see if I can get this going. So we're going to talk about practice changing and practice confirming. Disclosures. Okay, so big trials in the last year that have changed. Essentially changed our clinic practice overnight, include that list in locally advanced metastatic side. And then a few adjuvant trials are definitely worth reviewing that are new or either gave updates in the last year that are very relevant to our practice. So I'm going to start with Destiny Breast 06. So just to give a little background, because I'm not sure how many people in the audience are medical oncology or other roles. Trastuzumab deruxtecan has made a huge impact on our patients. This is a HER2 drug antibody conjugate. We have our HER2 positive population of breast cancer. That's about 20% of breast cancer. And this drug allowed the delivery of a chemo agent directly to a HER2 positive breast cancer cell. So that's a big deal. I would like to get out of what I refer to as old school chemotherapy, just cytotoxic chemotherapy that's hitting the good cells and the bad. I'd like to do something smarter. So trastuzumab deruxtecan really made a big impact. So Destiny Breast 01, 2, and 3 were in the HER2 positive population. And then DB04 was a really big deal because they realized this drug is showing activity in HER2 low patients. So that trial looked at our hormone receptor positive population where we're thinking endocrine therapy, and then when that's not working anymore, we move to chemo. But can we use TDXD and also get a benefit? So they looked in the DB04 at patients who had undergone endocrine therapy and then a few lines of chemo. So they're really kind of in the thick of it now, really undergoing intense treatment, and used TDXD, and it was a very positive trial. So DB06 is a big deal because they said, what if after those patients progress on endocrine therapy, we then go straight to TDXD before chemo? So this trial is looking at pushing chemo out further and doing TDXD first. And so this was originally presented at ASCO in June. Again, they looked at HER2 low, hormone receptor positive patients, and they randomized to TDXD, this HER2 antibody drug conjugate, versus physician's choice of chemo. And primary endpoint was progression-free survival in the HER2 low population. Very important and interesting. I don't know if that's too small, but it was just to point out in the patient population, we also are identifying a HER2 ultra low population. So you're really starting to wonder, does it matter if they're HER2 positive or not? But this is really opening up this opportunity for this drug to a large population of women. And the other red block, which you probably can't see, is just to point out that there was a high percentage of patients with visceral disease. So meaning not just bone only, hormone receptor positive metastatic disease, but they have disease in their organs and their liver. And so this was a very positive trial. Let me see if I can get the pointer to work. Perfect. So the middle here shows the intent to treat populations. That means the HER2 low and HER2 ultra low. And you see the way those curves separate. It was clearly statistically significant in regards to the median progression-free survival. This top graph shows the HER2 low population, and the bottom graph shows the HER2 ultra low. And though it wasn't powered necessarily to look at HER2 ultra low, this was giving us important information that this drug is having activity in could be the whole population of patients. And so when I'm thinking about this in the clinic, okay, now I know that I'm going to be looking to use this drug, that my patient could get more benefit from this than chemotherapy. The first thing that comes to mind when you're thinking about a stage 4 patient is they're not curable. Their quality of life is very important. Shared decision-making with the patient and what their goals are is very important. And often what a lot of us use is a drug like capecitabine because it's oral and you don't have hair loss. So before they end up in the infusion and they're going through these heavier side effects, that's what we'll often use as a bridge prior to IV chemo. But this trial showed that the TDXD was clearly superior also in the groups that got capecitabine, which was a large quantity of the patients. And so, and most common drug-related side effects, I won't talk about that too much because it was fairly similar, with the exception we know that we have to look out for interstitial lung disease with TDXD, and we're kind of used to managing that. So overall, there wasn't any signals that there's a lot more toxicity per se on either side. And so the big update at San Antonio in December was a subgroup analysis, and I think this is very helpful to us too. They looked at patients who were, you would consider endocrine refractory. So if I have a patient that's diagnosed with stage 4 hormone receptor positive breast cancer and they've either quickly recurred after their adjuvant therapy, right? They thought they were curable and now they're recurring, or they're de novo stage 4. If they progress through that first line of endocrine therapy quickly, I'm very worried because you want the first treatment you do to last as long as possible, and that kind of gives you an idea about their trajectory of their disease. So if a patient is progressing very quickly on their first line of treatment, that's a poor prognosis. And so what they showed here in this first graph is the patients that progress within 6 months, you see this very large difference in the curves. There was a very large delta. This writing is so small, I apologize. Median progression-free survival, 14 months versus 6 months. So that's a huge benefit. So it's wonderful to know, like, I have this drug now that I can give a patient optimism that they're likely to respond when they've progressed so quickly on their first line. And if you look at the other two graphs, it shows that there's still clear benefit in all patients. Even if they've been on their endocrine therapy for a prolonged time, the benefit just wasn't of the same magnitude. I didn't include, but nice to think about too, the other subgroup analysis were overall response rate. So say I have a patient that has a very high tumor burden. They have a large burden of tumors in their liver, and I'm very worried about if that may progress and may cause abnormal liver function. I know that I can get a good response rate with this drug, so that can be clinically applicable. Additionally, they even looked at progression-free survival too. So meaning if I use the TDXD now as opposed to later, how does this change their responses to their next line of treatment? And it was still very, very positive. Median progression-free survival was statistically significant by quite a few months. So overall, this is a big impact for us in medical oncology in terms of how we use this drug. So the FDA approval was only 2 months ago, showing now that we have the FDA approval to use the drug in this way. So the key here is this HER2 ultra-low population. This creates a little bit of a challenge because this is not something that pathology normally reports. We haven't needed this information before. This entity really wasn't recognized as, as targetable. And so that's not something that's being done, at least yet where I am. And I think at big centers, they've probably already started to develop this, but this is something we're going to get our pathology colleagues involved in. And I don't envy their job there because that is difficult to decide how you define HER2 ultra low, right? In the trial, they just said basically if there's any immunohistochemical staining on the cell for HER2, then we can use it. But that's still a little bit challenging in practice. So that's something very actively we have to work on now in practice to serve our patients best. So that was a very exciting trial. All right, so patina. So this is I put San Antonio Surprise. They got the results for this trial the Thursday before the meeting in December, and then essentially put all of this together to present it. And so the patina trial was asking, in the first-line metastatic hormone receptor positive, HER2 positive setting, can you add a CDK4/6 inhibitor to the anti-HER2 therapy, right? So right now, if a patient has HER2 positive disease, they get anti-HER2 therapy. It doesn't matter if their estrogen is positive or not. We don't target that, right? If they're estrogen receptor positive, we target that over here, and then triple negative, of course, we don't have those targets. So this was saying, should we not be thinking about this in a way that we're going to give the more potent, estrogen receptor positive treatment also with the anti-HER2. And there's a lot of good background studies to show that CDK4/6 inhibitor pathway, or I'm sorry, not inhibitor, the pathway, we want to use the inhibitor, works in synergy with the HER2 pathway. And so they took patients, they receiving standard of care, which is the Cleopatra regimen. They get a taxane and they get HP, and they get 6 to 8 cycles of that, and then they complete their taxane and they move on to HP maintenance. And they randomized 1-to-1. The patients that are estrogen receptor positive were going to give their aromatase inhibitor plus palbociclib, right? So the standard CDK4/6 inhibitor that we're very familiar with versus placebo. And so the results were really amazing. Key characteristics, I don't think there's anything really important to mention there. And so, again, this graph might be small there. I mean, you can clearly see the separation of the curves. But what's really interesting is this median progression-free survival in the anti-HER2 group, just receiving their Herceptin Perjeta, was 29 months. And that's a really long median progression-free survival. We're talking over 2 years of just being on their standard therapy. So that was unexpected. That's much longer than you expect. And then the experimental arm where we added palbociclib was 44 months. So the idea that you're starting out on this journey with a patient and this is their first-line treatment, and you can say there's a good chance this is going to work for maybe up to 4 years or more is pretty incredible. And so there was a lot of interesting conversation about this because it made such a big difference. I said, well, why was the control arm, so much better than expected? 26 months when the Cleopatra data showed a median progression-free survival like in the 18-month range. And they realized 2 important things. First, in the Cleopatra trial, they didn't use any endocrine therapy, right? So we would put everybody on an aromatase inhibitor at least, but they didn't use that. And number 2, in this trial, they waited until after the chemo. So the first question I'm thinking as a community oncologist too is, can I take the chemo out? Patients would be really happy about that. But essentially, this is selecting for a group that responded to chemo. So there was a certain percentage of patients that progressed quickly, and then they didn't move forward with the trial. So this is nice from the standpoint of telling us what population really would benefit from this intervention. If they go through their chemotherapy and then they're on their maintenance HP, if they're estrogen receptor positive, then this essentially, I think, changes standard of care overnight. And the median overall survival is still not resulted. It was, I think, 77 months in the standard arm. So this is a really great trial. I think about, 50% of your HER2 positive patients will be estrogen receptor positive. There's tons of patients I can think of that I'm like, oh, I wish I would have had this for them in the past, and now I know I'm going to be able to apply it in the future. So that was definitely a practice-changing trial. Given synchronously, correct. So as soon as they're done with the chemotherapy, you add palbo. All right, and adverse events, we're very familiar with palbociclib because we've already used it for years. There was really no signals of anything very concerning, nothing unusual, nothing. So overall, well-tolerated regimen. So this was really exciting and a clinically meaningful improvement in PFS and absolutely, I think, changes practice. So interesting to think about is, like we were mentioning earlier, trastuzumab deruxtecan, TDXT is such an amazing drug, and it's made great strides in HER2 positive and now HER2 low. And so DESTINY-Breast09 is going to be coming out, and it's going to be challenging the first-line treatment in HER2 positive metastatic disease. So what do we do with that information then? Because that's going to change this paradigm. But I think about this and think I kind of like to have these problems. These patients are doing so well, and our treatments are getting so much better that we're talking in years. So it's challenging when this research is going on and resulting at the same time. And how do you put it together? But I think we're going to be able to keep working through that with new trial designs. Okay, so moving on to TROPION-Breast01. So antibody drug conjugates like TDXD that I was just mentioning, right? These are, this is definitely kind of the future. There's more and more of these drugs in development. They're combining them with immunotherapy and with oral agents. And so this is a new ADC that's now FDA approved as of a few months ago and is in the NCCN guidelines, so important for us to get updated on. So Dato-DXd uses the TROP2 target, which we are familiar with in sacituzumab govitecan, and the deruxtecan from the TDXD. So TROP2, we know there's a very high proportion of this on triple-negative breast cancer, and now they're finding on all breast cancer cells and other cancer types. This is being tested there as well. So this Dato-DXd, the question was asked, does this improve PFS compared to chemo in a pre-treated metastatic hormone receptor population? So pre-treated in this case meaning they've gone through their endocrine therapy, they've gotten a few lines of chemo, and now we're using the antibody drug conjugate. And so overall eligibility criteria is what I just described. They could have had 1 versus 2 previous lines of chemo, and they stratified according to that. And they were randomized 1-to-1, Dato-DXd versus, again, standard chemotherapy investigator's choice. They had dual primary endpoints of PFS and OS. And again, you see nice separation of curves. This was a positive study. Now, when we're talking about TDXD and the patina and the numbers that I was just mentioning, right, the physician's choice of chemo median progression-free survival here is 4.9 months, and the Dato-DXd is 6.9. It's a modest benefit when you think in that context. But this is a heavily pretreated population, and this trial did lead to an FDA approval and in the NCCN guidelines as an option. In the big picture in the future, as we're getting all of these drugs as options, like what am I supposed to use, which again is a good problem, we're going to see, I think, like this drug is already showing great potential in immunotherapy combinations and trials ongoing and in the neoadjuvant setting, right? That's really exciting. Not just can we help patients live longer that are stage 4, but can we cure more patients? So, so interesting side effect about this drug that's important for us to think about that's a little different. They have more ocular side effects, dry eye, keratitis. It's interesting to me, I noticed just thinking about if I were to try to talk to a patient about this, they advised that no patients could wear contacts and that they needed to establish with an ophthalmologist immediately and use preservative-free drops in their eyes throughout the day. And immediately, again, just trying to be practical, I'm like, I think that would turn off some patients. Maybe they never wear contacts. Maybe they don't, maybe they always wear contacts. Maybe they don't want to wear glasses. Maybe they're not going to be compliant with putting in those drops so often. Just kind of practical things to think about. So that was one thing that's unusual about this drug. And as we start to use it, we have to think about that. So the FDA approval came through for this drug, and the NCCN now listed as an option. Of course, we have our other antibody drug conjugates listed there also. So we're definitely getting more options. All right, so changing gears now, this is an oral agent we're going to talk about. So INAVO120 was presented at ASCO and published in 2024, and this drug is now also FDA approved. And so this question is asking, can we improve outcomes for metastatic patients with PIK3CA mutated tumors? So this is something that develops in hormone receptor positive patients. If they have a history of hormone receptor positive breast cancer and they recur quickly after treatment, or if they're metastatic, they're getting their first line CDK4/6 inhibitor and they progress, we look for this mutation. So you could say this mutation is as a more poor prognostic phenotype. This is more like the serial killer in the prom dates. So you want to know about this. So they asked the question, instead of looking for this after a patient progresses on CDK4/6 inhibitor, should we be looking for this sooner if a patient has had endocrine therapy in the recent past or recurred quickly, so that we can combine the CDK4/6 and the PIK3CA targets? All right, so study design is kind of as I just described. It was 1-to-1 double blind with a placebo where they used palbociclib, our CDK4/6 inhibitor, fulvestrant, standard endocrine therapy, and inavolisib versus placebo, targeting that PI3K mutation. And again, things that I pay attention to when I'm looking at the patient population, they were evenly matched. And these are patients that had a high percentage of visceral disease. So again, you're automatically thinking about, these are more poor prognostic patients. And a very positive study. So median progression-free survival, which was the primary endpoint, was met 15 months versus 7 months. So that's very meaningful. I'm hopeful when I start a patient on their first-line therapy that are hormone receptor positive that they might be able to be on their CDK4/6 inhibitor for years. And this is automatically showing you a patient that they progressed within 7 months. And now we know it's very likely that the PIK3 mutation has something to do with that. So in the past, right, so the FDA approved this drug, published in 2024 and FDA approved. In the past, we're only looking for that mutation after they've progressed on their CDK4/6 inhibitor. And so this trial really changes that. This says we need to be looking for this sooner and look for this in patients that have recurred quickly, so that we can identify this more high-risk population up front. And so this PIK3CA mutation that I'm mentioning, that was pictured on the slide that Dr. Borgen showed. It's a very overwhelming slide. I've seen pictures like that many times, and that really is the perfect example, again, of the 87 different types of breast cancer. And so as we're getting all this data, and it can be overwhelming. There's a lot. It matters. It's what's going to help our patients, move forward with better outcomes and move the needle. So these trials are kind of a good example of that. All right, so moving on to EMBER-3. So this is in the realm of oral SERDs. We know that we have some approvals and uses of oral SERDs now with elacestrant. We have chemivicestrant now. So at San Antonio, just in December, EMBER-3 was a study looking at imlunestrant, right? So we use SERMs as tamoxifen, right? Aromatase inhibitor is anastrozole, letrozole. These are pills that patients take, exemestane. And then SERDs is an estrogen receptor, preventing estrogen receptor, or causing degradation, rather, not preventing. So we use fulvestrant right now. That's an injection. It's not pleasant. It's well tolerated, but this is an intramuscular injection. So if my patient's progressing on one of the other endocrine therapies, then we move to that. So this is offering an oral option now. So we know also that part of the bioavailability of giving that injection is not as good as these oral options. So that's where this development stems from. And then this can be another partner when we're using CDK4/6 inhibitors and other drugs in the future, is how I think about it. So this trial looked at this novel oral imlunestrant, this oral SERD, versus a standard endocrine option like the fulvestrant injection or exemestane. And then as they started the trial, they realized, it would be more useful and smart to combine this with a CDK4/6 inhibitor, because I really don't have that many patients now that I only give them endocrine therapy alone. It's not per se standard of care unless you have a handful of patients that have a different kind of behavior with their cancer. So they added a third arm of imlunestrant plus abemaciclib. So we have a CDK4/6 inhibitor partner. And the primary endpoints we're looking at PFS in all of these populations, and then very specifically in what you call an ESR1 mutated population. So again, speaking to this 87 different subtypes, we know that if you give a patient an aromatase inhibitor over time, their estrogen receptor pathway can develop a mutation to where that receptor stays on. And it doesn't matter if I'm giving them the aromatase inhibitor and lowering estrogen, it's on now. So this ESR1 mutated population is important for me to know about also. That can tell me why my patient's treatment's not working anymore, and then we want to find a way around that. So that's what these drugs can also do. So, baseline demographic and disease characteristics, they made sure there was a certain number of ESR1 mutated patients. There was about 40%. And they also had the PI3K mutation identified and wanted to know if it helped that population. So we are getting smarter about realizing what populations and with what mutations and changes in their tumor do we need to be cognizant of when we're making these treatment decisions and trial design. And so when they looked at imlunestrant versus fulvestrant without the ESR1 mutation, they look similar. So I don't take that as a big surprise. But they both have similar efficacy. But if they look in the ESR1 mutated population, the patients that have developed a mutation in their estrogen receptor pathway, there's no question that this oral SERD is better, is superior. The median progression-free survival was 5.5 versus 3.8 months. It has a ratio of 0.6. All of this was very statistically significant. But then more interesting, of course, is I want to see what does it look like with the CDK4/6 inhibitor, because that's what I want to think about for my patients. And in this case, very important, patients that had prior CDK4/6 inhibitor exposure in about 60% of the population. So that's very interesting. Can I keep using a CDK4/6 inhibitor, but just change the endocrine partner, essentially? And this was a positive trial, 5.5 months PFS versus 9.4 if you had the abemaciclib. So these are important developments. I don't know exactly how this one's going to change standard of care as much, because this is a kind of crowded room right now in terms of first-line and second-line endocrine, but it's meaningful and definitely going to make an impact going forward as they continue to study this. So again, the ESR1 mutation, whether they had that or not with the abemaciclib, it was still superior, so very helpful to know that. So design considerations, again, it's hard to figure out. I would like to see what if we know they're PI3K mutated, why aren't we using the PI3K target plus endocrine therapy? So it's a little bit complex, I think, how to use this data right now. But again, I think this is going to become more clear over time. Okay, NATALEE trial. So we're switching gears. All of those trials have given us new data in the metastatic setting. And now we're going to talk about a few trials in the adjuvant setting. So in the metastatic setting, our goals are to prolong life, improve quality of life during that time. In the adjuvant setting, can we achieve more cures? Can we decrease recurrence risks? So can we pick out, what patients are higher risk and how can we cater treatment to them? So the NATALEE trial was reported last year, and this is an adjuvant CDK4/6 inhibitor we use often, ribociclib. We've used this for a while in the stage 4 setting, and they've looked now at 2 other CDK4/6 inhibitors in the adjuvant setting. The PALLAS trial was a negative study, so we don't use Palbo in that setting. The Monarch-E trial was positive and very impactful, so it is standard now to consider 2 years of abemaciclib in a specific high-risk population. So this is stage 2, stage 3 with higher risk characteristics. And so NATALEE is asking the question, does ribociclib improve outcomes in the adjuvant setting? All right, and so again, I highlight things that are of interest to me, and I think that are of interest to the results of the trial. There are quite a bit of premenopausal and postmenopausal patients, so I'm thinking about my younger patients that I'm concerned about risk. And very importantly in this trial, as opposed to the Monarch-E trial, was the N0 population. So when they first looked in this abemaciclib trial, they did not allow any lymph node negative, but they did allow that in the NATALEE trial. And the final analysis of their primary endpoint of invasive disease-free survival was just published a few months ago. They had preliminary results last year, and then this is the update. It is statistically significant. When you look at curves like this, you don't see the big separation, but this is going to take time, and you're going to continue to see it, and it is statistically significant. And again, this is from the standpoint of I'm hoping to cure more patients, not just prolong life. So I think this is going to continue to be meaningful. And then this presents the opportunity to say, where are there situations where we may be avoiding chemotherapy and using drugs like this? And this is certainly very, very relevant. You look at the clinical trial population, and then you look at your population in the clinic. Do my clinic patients look like the patient on the trial? What about their comorbidities? What about their age? I believe the average age in these trials is in the 50s. So it's a matter of, this is very helpful when making those decisions. And there were no subgroups here that didn't benefit. If you see where the line crosses 1.0 is, did they get prior chemo? 80% of patients in the trial got prior chemo. That's a very small group. And then grade 1, we're not worried about the grade 1 population. Most of this population in this trial was higher risk, grade 3 or Ki67 over 60%, or could have a high genomic assay, a high oncotype, a high mammoprint. So that's going to be very helpful. So now we have 2 drugs that we can use in the adjuvant setting. Right, the Monarch-E data is for abemaciclib times 2 years, and this trial is a little more mature now, so we have data farther out. But what I like about this is abemaciclib was given for 2 years, and if you look at these curves as you continue past the 2-year mark, they continue to separate. So this is very important in regards to feeling like then hopefully we are achieving more cures in a higher risk population. So this graph, I keep in my phone now so I can refer back to it. One of the challenges is that Natalie's population, right, is a little different. The criteria in regards to risk is a little different in what they allowed. And so, very importantly, ribociclib in this setting included some node negative patients, as opposed to that was not the case in abemaciclib. And so you can see where this at least kind of illustrates for you, and we can go back and use this to decide. You know, I have these conversations with patients about which drug may be best for them, right? Abemaciclib was 2 years, ribociclib was 3. The monarchy data, of course, is a little more mature at this point, but it's great to have more options for patients that you're concerned are high risk, and patients are happy to continue to be on treatment. They don't, you know, they're happy to get past chemotherapy, but they're also like, what am I doing now, or what more can I do to decrease my chance of my cancer recurring? And so in these higher risk population, this is very impactful. I'm at time, I'm close. Let's see, the last few I just wanted to reference. They had a nice publication and talks in the last year about reducing the dose of abemaciclib in the adjuvant setting. We very, very commonly have to reduce the dose of that drug. Diarrhea is the main side effect. There are other side effects, but diarrhea can be very limiting. So they showed a very nice publication that even if you decrease the dose, the drug is still effective. So this is helpful when I'm counseling patients. They are hesitant to decrease the dose because what if it doesn't work? And I can say I feel comfortable that this drug is still going to give you a benefit even if we decrease the dose. So that has been very helpful. I'm going to pass up that one and just go to the Olympia. So Olympia was an adjuvant trial for BRCA-positive patients who were high risk to recur. And so they gave a PARP inhibitor for 1 year adjuvant after their chemotherapy and such. These patients all got chemotherapy. So the 10-year update was reported at San Antonio. So that, right, this trial is asking the question, can we decrease recurrence and increase the cure in the adjuvant setting in breast cancer with a PARP inhibitor in these BRCA-positive patients? And so as time has gone on, and again, I mentioned in this case that that drug was only given for 1 year, olaparib's only given for 1 year, the abemaciclib 2 years, the ribo 3 years. It's kind of a lot to digest sometimes. After only 1 year of that PARP inhibitor, this is how the curves continue to separate over time. So that's very impactful. There's overall survival benefit for these patients, and to see the curves continue to separate is very reassuring. Other things they looked at were CNS recurrences. There were very few. And this is according to hormone receptor status. If you look at this slide, hormone receptor positive or negative both benefited, even though there were, of course, more hormone receptor negative present on the trial. So adverse events of special interest over time, new primary malignancies, there were less ovarian cancers in the patients that got the PARP inhibitor, which is interesting. CNS recurrences were also decreased. So overall, this was just very reassuring. This is an important drug, and when you're making those adjuvant treatment choices, this one is kind of a simpler choice for us. They're BRCA positive and are in that high risk stage 2-3 population. This drug is of great benefit. So this is a patient of mine who has stage 4 breast cancer. This was her Mardi Gras outfit. She's an amazing human. She inspires us every time she comes in the clinic, like a lot of our patients. It's a great privilege to get to take care of these patients. That's it.